And the webinar's live.
Thank you very much, Noreen. Hello, my name is Andrew Wilson. I'm chair of NHS Cheshire CCG, and welcome to the CCG's governing body meeting for November. You will have, of course, noticed that this meeting is a virtual meeting for reasons of the COVID-19 pandemic. We're not holding our meetings in public person to person anymore. We hope that this forum allows interaction with the public in terms of the questions, but it is a reminder that it is a meeting held in public rather than a public meeting. We do have a section for questions from the public, and welcome to the members of the public who are either attending live or will watch the recording of this meeting. As I said, we're having the meeting virtually because of reasons of COVID-19, and of course we are seeing an increase in the number of COVID-19 cases once again, and it would seem remiss not to mention that as a context for our meeting, and with the sadness that brings in terms of increased illness and unfortunately increase in deaths in our communities. We have got a short video in a while which illustrates some of the burden that COVID-19 brings, so that will offer a sort of framework for our meetings and discussions. As I often have at the start of these meetings, I want to thank all the staff across health and care who are delivering both COVID response and the really important non-COVID work that still needs to go on. When colleagues across those services have been working extraordinarily hard to keep services both COVID and non-COVID going, and I'm sure that all governing body members would want to join me in our thanks to those people, but perhaps also our thanks to their communities who are remaining resilient and innovative and showing great care and compassion in helping everybody get through what is a very difficult time. Being slightly parochial, I did want to mention just two groups of people in particular for thanks. One being our exec team and their teams. Commissioning can be a sort of Cinderella service within the health service at times. I just want to highlight how hard people have been working now for the last 8 to 9 months in response to COVID and to get non-COVID services going. So our thanks to them, because it has, I know, been very, very hard work and great deal of stress, and it continues, doesn't it, unfortunately. And also, again, slightly parochially, to our GP practices who, as a member organisation, it seems right to mention them, who have returned their services back to pre-COVID levels of activity, but in addition are in the middle of delivering the largest flu campaign ever, and was planning for the delivery of the largest vaccination programme ever. So our thanks to colleagues in practice who are working hard to do those things. I think all that just underlies that this is a stress on everybody, stress on our communities across Cheshire, and it's been going on for 8 or 9 months, and it is a real strain. It is tough, and a number of meetings I've been in recent weeks, what's really come forward is an acknowledgement of the psychological stress and strains that's putting on people, and that really is okay not to be okay. Keep talking to each other and be kind, and reminder for the governing body in the context of our values, which include compassion and caring, that we need to be kind and compassionate to ourselves and to each other through what is a very, very difficult time. Enough from me. Let's move on to our important meeting. And can I ask, I don't think that we have any prior confirmed apologies, but Christine, do we have any apologies to confirm? I'll take silence as a no from Christine, thank you. And I can confirm that we are quorate, so we can move on, and we'll move on to our declarations of interest. Governing body members are asked to check their declarations of interest on the website, which should all be up to date, but in particular, we're interested in declarations which specifically relate to items on the agenda today. I will mention that there is on the REMCON paper, which we'll deal with when we come to it, some potential conflicts of interest. So we'll deal with those at the start of that paper, which concern GPs on that occasion. That takes us then to the consideration of our minutes from our last meeting, which start on page 3. Are there any corrections to the minutes on page 3, page 4, page 5, page 6, page 7, page 8, page 9, page 10. I know that in advance we have had a note to say that we missed Christine off the attendance list for this meeting, so we will correct that. With that exception, are there any other points to raise? No, thank you. That takes us. So Linda, you say you have a change. You want to come in and discuss that?
It's for the next set of minutes. I was just doing it in advance, so you knew.
Okay, thank you. You're too quick for me. So that takes us to the next set. We have a set of meetings of an extraordinary meeting, which starts on page 11. For page 12, page 13, we do have. So Linda, you want to come in?
So page 13, bullet 6. I think it's quite easy. We have lots of 3-letter abbreviations. I think it should say receive funding on that should be the HDP, which is the hospital discharge program, as opposed to the HCP, I think. So I will confirm that with our minute taker today, Christine, and get that changed. It's just a small change of where the money's coming from.
Absolutely, and it probably should be written as hospital discharge program rather than as a 3-letter abbreviation, shouldn't it? So,
yeah.
Thank you.
Yeah. Thank you.
That's page 13, page 14, page 15. No, thank you. So that takes us then to our action log. So we have action number 11, 14 and 15, all of which are ongoing. So Tracy, do you want to comment on the first action? Your name against?
Yes, thank you, Chair. So action 11, it's suggested that when we committed to bringing something to the governing body now, this November meeting. So you'll see in section 4.1 of the accountable officer's report that describes that we're waiting for a response from our 2 integrated care partnerships. So that will come potentially in December, but I'd just like to highlight that in view of COVID, we may need to push that back potentially to January because our ICPs are working on the response to COVID and other essential aspects, but that's detailed more in section 4.1. So I think it can remain open and it's on the forward planner to come back.
Okay, thank you. So you can put it on the forward planner with a backstop date of January, should we, to be pragmatic, and we may be able to hear it before. Thank you. So item 14 says ongoing, but it's completed really because it is on the agenda for today. And then item 15 is designated premises for West, and that was on the agenda but has been withdrawn, and I believe we're going to take it at a future meeting, potentially an extraordinary meeting. Is that correct, Tracy?
Do you want me to pick this up, Tracy? It's Neil here. It was actually Chase that was on the agenda that's been withdrawn.
Sorry, my apologies. Yes.
Yeah, we've not. The local authority is still attempting to find a suitable location within Cheshire East that they could commission the designated beds from. So that will at some point hopefully return, but as it stands, we've not been able to commission additional designated beds in Cheshire East.
And so your advice on that action? Do we need to...
The advice on this action is as described with the update from Jamila. The only thing I would add is it remains a real challenge, discharge into the community because of infection control, COVID outbreaks, capacity constraints, and that's not unique to either Cheshire West or Cheshire East. It's a general point nationally, and we continue to work hard with our local authority colleagues on ensuring that patients don't get prolonged delays in hospital whilst we seek suitable discharge arrangements for them. But as described here, that has been implemented as described.
So it's going to be an ongoing action.
Yes, it will be an ongoing action as long as the current pandemic remains, I would suggest, with the difficulties in maintaining safe discharge arrangements where we're not moving people potentially into an area where they may either become infected or infect others because of onward transmission.
So thank you. So I suppose my question is, it clearly is something that needs to be on the CCG's agenda at some point. Does it need to stay as a CCG action point, I suppose is my, sorry, as a governing body action point?
Yeah, I'm not sure it needs to sit here. It is being managed through the governance of the A&E Delivery Board. So it is being managed across the system, and obviously the A&E Delivery Board includes the providers, the commissioners from both CCG and local authorities. So those involved are actively overseeing this risk.
Okay, so can I, unless colleagues disagree, that I suggest that we take that action off. It will sit with the A&E Delivery Board. It will come to us if there's a decision on procurement or spending, won't it? Is anybody in agreement or disagreement with that? Okay, we'll deal with that in that way then, thank you. So that takes us to, I believe, our patient story. And I think we have a video, the video that I referenced at the start of the meeting. So this is relating to COVID and the impact of COVID.
Hi everyone, I'm Paul. I got COVID back in March when I was 44 years old. I was in hospital for 75 days, of 35 of which I was on a ventilator. I got out of hospital on the 19th of June, and thankfully I'm one of the lucky ones. I'm recovering pretty well, even though I'm not back at work yet. Thanks to the skillful team of nurses, doctors and physios, I've been able to walk, talk and just try and get my life back. As we enter a lockdown, follow the advice, wear a mask, wash your hands, save yourself and your loved ones and the NHS. This is a real illness, it's a real virus, and it's happening across the world and in our country. So do what you can to save lives. Thank you.
Thank you for that. Clearly a short video, but I think one that does, as I said at the start, frame some of the challenges that society and particularly the health and care services are facing at present, and really illustrates that the effects of COVID are not just about serious illness in terms of being on a ventilator, and they clearly are for some people, but also some people who have mild illness have got significant longer standing problems following this infection. I will pause in case colleagues want to make any comments on that. And just a reminder. So I'm asked in the chat bar about how do you get my attention, and there isn't a hands up function on this platform, so it is by typing into the chat bar. So just typing, "Can I talk, please?" or something. Okay, lovely, thank you. So I'm assuming nobody did want to comment on that, and we'll take that as our frame for our following discussions, and we'll move forward to the public questions and answers. And I believe that we don't have at this stage any questions from the public. Is that correct, or has that changed? So let's anybody notifies me that position has changed. I'm going to take it that at the moment we have no questions. Thank you. So we'll move forward, and we're moving on to the Accountable Officer's report. So Claire, please.
Thank you. Thanks, Andrew. And I think that's a really powerful patient story, and just sort of testament to how important it is that partners work together. And I'd like to reiterate Dr. Wilson's thanks to all CCG staff, the exec team, and obviously to our wider frontline staff partners across Cheshire and beyond. There's clearly intense pressure on everybody at the moment, so massive thanks to everyone's work. I'm going to take it you've read the report. Obviously, this report highlights areas of responsibility for the CCG that don't really highlight elsewhere in the governing body papers. So I'm assuming you've read it. So I'm just going to pick out 2 or 3 key points, really. Clearly, we're in national lockdown again, hopefully coming out on the 2nd of December. NHS is in level 4 emergency preparedness. An awful lot of work's going on, so I'm not going to sort of repeat that because everyone knows that. But I just want to sort of say a special thank you to Tracy, Neil and Chris Lees in terms of the work they're doing around the mass vaccination campaign at the moment. The GP Directed Enhanced Service came out 9 o'clock last Monday evening, and we are working incredibly hard, and a massive thank you to the primary care networks and our colleagues in integrated care partnerships for all the work they're doing. But there's an awful lot to do. Clearly, we are looking at a national campaign, looking at a Cheshire solution, working with everybody. And I think, you know, Trace's leadership and Neil around primary care have got a grip on this really, really quickly. So thank you. We will be having regular updates in the Friday newsletter around this, and there'll be communications, you know, left, right and centre. So please look out for that. But there is an awful lot to do. You can see that we've met our membership practices in the last couple of weeks. Again, thank you to them. Key messages for them are in terms of how busy they are and how we want to try and change the relationship with our public. A comms campaign is due out in terms of we're in this together, and I think that's really important as we go forward. In item 6, just in terms of the commissioning of the community equipment store, we had this conversation at the last meeting last month. A decision will be made, or a recommendation will be made on tomorrow, 20th. And what we're asking and recommending is the final sort of sign off and decision for that new provider and moving that agenda forward, so we get a new provider for the 1st of April, that we delegate that to Strategic Commissioning and Performance Committee. So at the end of this update, I'll ask for that to be a recommendation. This week we've got 2 national campaigns, Safeguarding Adults Week and Self-Care, both equally important for different reasons. Clearly it's everyone's responsibility around safeguarding, and as a CCG we have our obviously statutory responsibilities around that, and self-care as part of that whole continuum in terms of health and care, so we need to focus on those. 111 First went live at Mid Cheshire Hospitals Trust on the 10th of November, and it's going live at the Countess and East Cheshire Trust on the 24th of November. There will be a national campaign starting in December on this, so please be aware of that. Thank you to Dr. Sinead Clark for her day in the life of a Cheshire GP at the Cheshire Chat in October. I think that's really important, and that was well received in terms of, you know, how GPs work, the pressures on them, and how they're working with the wider primary care team and the public at the moment. Thank you to those of you who replied in terms of signing off and supporting the recommendation that the CCG will submit full compliance around our EPRR submission. It's really important that we have that full compliance, particularly at the moment when we're in level 4 as a national crisis, but also for all of our wider issues. And then finally, item 12 is a list of decisions made by the exec team, all of them within the CCG, SFIs and swords. So there's a list there. I think one of the things we haven't talked about recently, and I think maybe we need to bring something to the next month's agenda, is just a brief update on Brexit. Clearly Brexit sort of runs alongside COVID, winter, and everything else that's going on at the moment. And I think it'd be useful if we bring an update on that. So I'll bring something in the report. So that was all I wanted to say today, Andrew. So we're happy to take questions on any of the items. Thank you.
Thank you very much. Fiona has a question. Fiona, you want to come in, please?
Hi, thanks, Claire. As ever, very comprehensive, covers a lot of things. 2 questions. One was, just for clarity, can you just give us and a kind of an overview of what community equipment actually is. And the second one was about the 111 service, which is obviously started locally. And I know it's a national programme, but some of it at our practice we've already found works well, and some of it works less well. And what we were unclear about, and so GPs might need to know how we feed back into the whole system about, you know, what works well and what we can deliver. And for instance, them making promises that a GP might call them back within a certain time frame where they haven't told the GPs that, or whether it might actually be completely impossible to do that. So there's good things and bad things. We just need to be feeding our thoughts back.
Yeah, okay, thank you. If it's okay, Fiona, I'm going to defer to Tracy just to give us a sort of a very quick rundown of what is covered by community equipment store, and then Neil, I'm putting you on warning in terms of 111, please. Thank you.
Thanks. I don't want to get this wrong, but generally it's anything that's prescribed by our community services team, whether that's a district nurse, an occupational therapist or a physiotherapist, for moving and handling, or for any sort of equipment that someone may need for their mobility and recuperation. So there's a full list of what's in the spec, and rather than me say something that's not entirely accurate, I can share that with you outside, Fiona, if that'd be useful. But this is going to bring it together across Cheshire and make sure that we've got a better service. And we also heard last time about making sure that it's recyclable, which fits with the later agenda as well.
So the reason for the question was I wasn't sure if things like catheters and colostomy bags and that sort of thing were part of this, because that is something that we need to look at to make sure that there's no waste there with people who don't actually know what they're doing, with like myself, for instance, being asked to provide things and providing the wrong stuff. So I'm quite keen for it to be a well managed and therefore economically viable service.
So my understanding is that's separate, but that we have had a different project looking at that, Fiona, making sure that we've got a formulary across Cheshire and that everybody knows how to support patients well with that. Again, I don't want to say the wrong thing, so it'd be better if we come back and either handle that outside the meeting and give that clarity perhaps to a membership meeting, if all GPs would find that useful.
It might be helpful, Tracy, in the minutes if we can just put a list of the services in the minutes. Thank you.
Will do. Thank you.
Thanks. Neil, can I hand over to you for 111, just in terms of practice feedback? Thank you.
Indeed. So the 111 first is the programme looking at allowing people to pre-book before going to A&E. Now, of course, by pre-book, it doesn't assume that everyone who rings 111 needs to go to A&E, which I know has been I guess a myth that has been discussed in the past. So 111 first has just gone live at Leighton. And is due to go live next week at Countess and Macclesfield. The aim being to avoid people either unnecessarily attending A&E or attending A&E and potentially accessing a crowded waiting area, the risk of cross-infection and prolonged waits. So in terms of your specific question, which was around how do you feed back, there is an established mechanism within the 111 service for feedback on specific incidents, which we can share. But within the CCG team, we've got a gentleman called Jim Britt who fits into the regional rollout of NHS 111 more generally. And any incidents, Jim, working with some of our clinical leads, would review with NWAS. So we can share the standard address, but if you have got specific examples or concerns, Jim would be a prime contact to share those with, and he can link in with, as I say, we have a clinical lead who reviews the incidents raised and the themes being flagged by general practice or other parts of the system in relation to things that aren't working that well, and that then feeds into a regional process which Blackpool CCG and the clinical lead, a gentleman called Magnus Hurd from Blackpool, deal on in terms of working with Northwest Ambulance Service to improve the advice being given as you'll probably know, a lot of the advice is driven by a national system called NHS Pathways, which determines the outcome based on the information that the call handler receives from the patient, recognising, sometimes that may mean a slightly risk-averse disposition. But as I say, we can continue to learn and refine the algorithm and make sure that the staff in the call centres at North West Ambulance Service are fully following them.
Okay, thanks. So I think it would be useful if maybe on one of the webinars or one of the information things that come out, we have those email addresses so that that can be done. And certainly, I mean, I don't want to escalate every single time I get irritated about something. I would never be finished. So I think it's partly the themes and partly just to make sure that people aren't over promising on behalf of somebody else, because that's a concern. Yeah.
Certainly, I know that was picked up as part of the first wave of COVID. There were real concerns about people being promised a call back within 10 minutes kind of thing, and we do need to know about that. And if you have got trends, if you're having a practice meeting and you've got trends, it is useful to flag them via Jim, so that we are making sure that we aren't missing things, because I recognise your point that every single incident probably isn't going to get reported through the normal mechanisms.
Thank you. I think Andy wants to come in, Dr. McKelvey, to support that point.
Yeah, thanks, Dr. Wilson. Just to support Neil as well, he actually mentioned it later on in his answer. So it's about NHS Pathways, and they actually do take quite a conservative approach, and it's basically the ultimate is patient safety. So that's why it might be impactful on other providers. I think the intention really is to actually get patients seen in the right place at the right time by the right person, and sometimes that's not at the A&E department. So that's the reason for the 111 first. But I understand Fiona's comments, and I think if we do collate those themes, we could feed that back. But essentially, it's been set up by a national NHS pathway system, and it actually puts safety at the heart of things first, and hence some of the escalations some practitioners might question.
Thank you very much. We've got further questions for Claire's report, and I think Suzanne is next, please.
Yeah, it was just, we're talking about COVID. There's a lot of focus at the moment on the vaccine, and also we've had the patient story. I just wondered, as a CCG, what are we doing about the funds for long COVID, those who have already suffered and have long-term side effects from it? Is there anything we are commissioning to assist with that group from the 10 million fund that was announced?
Sorry, I've got problems with my microphone at the moment, and I've got my gardener outside as well. It's still quite early days with that, Suzanne. So we're working through with our partners and with Cheshire and Mersey on that, looking at what schemes are best across the Cheshire footprint, what schemes are best across the Cheshire and Mersey footprint. There's things like, this is probably not the best example for long COVID, but in terms of some of the mental health resilience hub that's been commissioned across Cheshire and Mersey rather than a single CCG. So it's still quite early days on that, but we're working through.
Okay,
but we're still getting back, Suzanne, both in terms of our commissioning contracting intentions, we'd build it into that, but also through any sort of updates before then.
Thank you. Andy, did you want to come back? You sort of physically put your hand up there, and it just...
Yeah, I'm struggling with the chat, so thanks, Andy. Yeah, I think it's a great question, and we are working with one of our areas, Living Well for Longer. So it's we've got clinical leads involved, and we've got one of our commissioning managerial team involved in actually looking at that. Obviously, it's a really complex virus. It affects so many systems within the body, and not least mental health. So it is a complex one. There are nationally commissioned services that I actually direct my patients to as your recovery, your COVID recovery plan. And it actually gives some good steers for patients to actually how they manage their own long-term improvement. But it's tricky. But locally in Cheshire, I'd like to give you some reassurance that we're on it, we're understanding it and working, as Claire says, with our partners. But it's complex. If there is some specific respiratory things, obviously, you know, early on when we started to understand long COVID, we were talking with our respiratory colleagues within the trusts. But it is very complex. So working that through with our local colleagues, trying to commission something comprehensively, it's a challenge, but we're on it. And as Claire says, it will need to be within our commissioning intentions too.
Thank you very much. A comment made in the chat bar, which is interesting, that there is a programme lead responsible for long COVID within the CCG, and a plan is being formulated. So for the reassurance of the public on that one. So I'm now going to move to Leslie, please, for a question for Claire.
Yeah, so sorry, I've got 3 questions, if that's okay. So just you mentioned about sort of self-care week, and as West Cheshire we used to have quite a big focus on this, and obviously it's difficult, I know, at the moment with this pressures of sort of dealing with COVID, but felt that it was important. You know, it's an important area as our focus as a strategy, and also it's important as far as COVID goes, with the fact that the more healthy people are, the more they look after themselves, the more better they are able to cope with the virus. So it's just about a question about sort of what we've done as a CCG, a little bit of an overview. The second question is in regards to the ICP funding. Just that it's non-recurrent, so I just wanted reassurance that I suppose that the stability of the ICPs is so paramount at the moment with a lot of the things that we're doing, and just reassurance that will continue. And the final question is just a short one. I was just wondering personally what the Mary Seacole programme was. So sorry, that 3 questions, so thank you.
Okay, thank you. So you can see in the links, if you can press on 7.7, it says in terms of the resources that the CCG's been sort of promoting in terms of self-care. But Matthew, I don't know whether you want to add anything else there before I answer the other 2 questions.
Can you hear me now? Sorry, I can get mute there. So in terms of wellbeing support, is that the ask? Sorry, Leslie. So,
yes, what,
so yeah.
What we've been doing in terms of the campaign this week.
So as a comms team, we've been putting out a lot of both the regional and national materials around that through our social media channels and our sort of press releases, as well as internally to our as well. So again, we're trying to work in partnership, as Claire has talked about earlier on, with both our partners at trust level and regional level to do this sort of campaign.
Okay, so yeah. Thank you. In terms of the ICP monies, what we were referring to in the decision from the exec team is the transformation development monies. I mean, it is 0.2% of the CCG's budget, so we're not talking about a lot of money. This is money that through the healthcare partnership approach, we've been asked to top slice and to put into place, and so that's what we've been doing from a CCG perspective. So it's circa just over £1 million per ICP. So I can't guarantee, and you can see later on in the decisions, what we said is we can't guarantee this is going to be recurrent. This will be dependent on our financial settlement. Our ambition is also always to support the ICPs, but I think the danger is we spend an awful lot of time both in the exec team and in conversations, excuse me, with the ICPs around this 0.2%, which is give or take £1 million, when actually we commission the ICPs in terms of the provider contracts, the partner contracts for the organisations within the ICP. So it's more than the £1 million, because obviously all the elements of the ICP is made up of tens of millions of pounds of contract value. So we, you know, we've got a paper last month about the commissioning roadmap. Hopefully the ICPs are coming and to the meeting next month, or as Tracy says, we may need to defer that to January in terms of an update. But the CCG will continue to support the ICPs in every way we can. but this is about a small amount of development monies. It isn't about the total budget for the ICPs. And then the third question, Leslie, in terms of Mary Sequel, this is a NHS Leadership Academy leadership development programme. It's had really good reports. We've had a number of staff who've been on it before, and there's currently a really good offer, if I'm honest, and it's about getting value for money for us, for the organisation, but it's also part of our wider OD program, organisational development programme. But this is a sort of a recognised qualification through the Leadership Academy, and so we've recommended that we'll support another tranche of staff to go through that.
That's great. Thank you very much.
Thanks, Leslie. Thank you.
Thank you for your question, Leslie. It's a complicated one, isn't it? There's also another sequel program, isn't it, which is the COVID rehabilitation program, which is also their sequel beds, aren't they? So there's it's easy to get confused about what we're talking about, isn't it?
Yes, of course. Well, it's the Mary Sequel, it's the individual, isn't it? So I think a number of parts of the NHS are badging themselves with that lady's name.
Yeah. Right. Matthew, you wanted to come in on the question about self-care.
Yeah, sorry, I'll be quick. Sorry, I'd be remiss of myself if I didn't mention the fact that for some time now, South Cheshire and Borough previously, and we've carried on with this as Cheshire CCG, have done a self-care award where we've helped to develop self-care champions, and we've continued to do that during the COVID period as well. So I'm happy to share those details with you. Noreen, who's supporting us today, has done loads of work on that one, but we have done a lot of work with community groups and organisations and schools to get them self-care sort of champions to spread that message, and we've been doing that for a number of years, and we put that out in all of our sort of media releases. So just wanted to mention, because that is a great piece of work that has been nationally recognised as well.
Thanks, Matthew.
As far as I can see, there are no further questions on Claire item. So in that case, I'll move forward to our next agenda item, which is agenda item 4.1, which is the climate change strategy update. So
sorry,
Claire,
Andrew.
Sorry.
Can we just agree the recommendation about delegating the final decision around the community equipment store to SCAT, please?
Yes, sorry, I should have picked up on that. So the proposal is that we delegate to Strategic Commissioning and Performance Committee the final decision on sign-off to award a contract to whomever is selected by the procurement process that will be completed by that stage. So the suggestion is that we delegate to SCAT for that. Is everybody in agreement with that?
Thank you.
Yeah,
thank you.
Lovely. Thank you very much. My apologies for missing that part out.
Early saying thank you before people have said yes or no. So.
That moves us to item 4.1, which is the climate change strategy, and I'm very pleased that we are getting to discuss this. And my apologies again for colleagues and for members of the public that we didn't have time to discuss it in our previous meeting, and we got bumped. So I'm very glad that we're talking about it. It's been one of our major focuses as a CCG about how we want to make things different. But before we go on to talk about it, I do need to inform the governing body. I know that most governing body members are aware of the sad passing of Colin Watson. Most governing body members will recall that Colin came to speak to us about climate change, and it was he, amongst others, that set us along this path. So I think it was his leadership that led us to be in this position, to be here in this paper, and I think it's a great testament to him that we are sitting here doing that, because I don't think without his intervention and that with a small number of others that we would have this focus on climate change. And so I'm sure governing body members will want to join with me in sending our condolences to Colin's family, but also our thanks for his leadership on this work and for helping us be where we are on this issue. So our thanks as well as our condolences. So let's move on to the substance of the paper. I think Tracy, you're going to start leading on this for us. Before you do so, can I just ask that there's a focus, there's an ask for us in this of regarding So the point reads, agree a revised level of ambition and required resource allocation. So I think further clarity on that as you present would be very helpful in particular. So thank you. Tracy.
Thank you very much, Dr. Wilson. And yes, I join with you in the thanks and the tribute to Colin Watson. I think you're absolutely right to mention his impact on this work. It's been substantial. Also, would just like to apologise if there are any members of the public who joined last time who were eagerly awaiting hearing this item. I hope you understand that we wanted to give it the time that it needed rather than rush it last time. And just to start with some thanks, and then I am going to hand over to Bernadette Bailey, and then Dr. Gwydion Rees is going to finish with a rousing call to action, I believe. So just wanted to thank our climate change activists. This is about a movement of all of us and a change and a culture approach. And so we're very fortunate that we've got an active group of willing disciples and champions within the CCG who want to make personal changes and then impact on others. So a lot of the positive impacts that we can see, I think we need to recognise their inputs on that. And they're doing that on a voluntary basis. They've opted to be part of that group because it's something that they believe in and it fits with their personal values. And I think that's the appeal to all of us, to test our own personal values on this and think about how we can up our game as a very influential organisation across Cheshire. So I'm very pleased with this report. I think we should be very pleased to receive that. We are one of the few CCGs that I am aware of who have taken climate change and made sure it's on the governing body, that we have a governing body champion in Dr. Gwydion Rees, and that we have a plan, and that we are able to report progress over 6 months despite the COVID challenge. So I think the ask is to think about how we then take a step change. We're in 2020. If we're going to achieve net zero Cheshire by 2040, we need to do something different and radical. And I think as an influencing factor across Cheshire and Cheshire and Merseyside, because of the links that we've got, that's the call to action. And I think that Bernadette and Gwydion will go into some more detail as to what that means. So handing over to you guys.
Thank you, Tracy, and good morning, everybody. It's, as I said, an opportunity to come and talk to you today. Just give a few headlines from the paper that you've got, and particularly Appendix A shows where we are. Tracy's already mentioned the staff activists and that they are already starting to have great action across all of our teams. I was only hearing from, the discussions are going from sort of recycling, eco-bingo, right up to slavery, and actually our individual purchases. So our teams are starting to make individual changes, behavioural changes, which is a really great foundation for us to be building from. We've been successful in securing the funding for carbon literacy training for 100 staff across Cheshire and Merseyside. So we've set up a team to work with colleagues across the broader sort of sub-regional footprint, if you like, and working with within the social value action network that already exists, that has over 150 members of that. So we're positioning it and working with colleagues in our usual way of partnership on that. We aim to be delivering that training online coming into the new year. We just need to, at the point of signing off, a PID with Health Education England, and then we'll be into commissioning a trainer, as it's accredited training that needs to be delivered by a provider for us. We've also, just to highlight, working with the Mersey Forest and particularly the Natural Health Service, which has been operating in Cheshire West for a while, on a national pilot for a green prescribing bid, social prescribing that is. So another way of connecting and really putting climate and our environment right at the heart of the prescribing offer for all of our patients. But as I think we're bringing to you today, this is all great stuff. But actually this level of activity and progress on individuals, for individual patients or individual members of staff, is not going to be adequate to address the challenges we face globally, but for us specifically in the NHS. In the Delivering the Net Zero report, Simon Stevens has set us very challenging targets, and our response is required to address this. So it's our responsibility as a CCG to use all our resources, those we directly use, but most significantly those we use to commission healthcare. and to use that leadership power to both improve the health of the population, which climate change is so significant in all of that. We need to address the current and future health inequalities, and particularly poor environments, the air quality that has such a disproportionate effect on those people that are disadvantaged. So really we want to bring to you this question about what is the level of appetite? What over and above the actions we've already brought to you do you feel we should be taking? This is about, are we ready to take on a system leadership responsibility where we would prioritise climate change through all of our work? We've said that, but what does that, how do we make that real? How does it sit at the heart of all our work in contracts and with our, particularly through the integrated care partnerships that are developing? Are we ready to take on a national award? Are we prepared to actually say we're going to put this across all of our business and actually pursue some really set challenging targets? We could do that independently, but actually there are a number of organisations that could support us to do that. And one of the outstanding things for us is we don't know our carbon footprint. We don't know where we're starting. The net zero report gives us high level information for the NHS, but in order to know where we are going to be moving to or what our aspirations are, the view is generally we need a baseline. We either need to put some dedicated resource into doing that, or to consider commissioning an organisation, as both our local authorities have and all of those in Manchester, to actually help us develop and understand that baseline. So as sort of already picked up, what we're asking you to do is note the actions we've taken, particularly during COVID and all the challenges we've had. Note the publication of the Net Zero National Health Service and the challenges in there, and to consider its implications, which is if we want to continue to be bold and do more and follow a revised level of ambition, we will need to think about additional resources. At the moment, we're operating with some of my time and some of one of our undergraduates, and then elements from different service areas. But it's very loud, shall we say, at the moment, and great enthusiasm, but needing to consider where it sits for us. So on that, I'll just hand over to Dr. Gwydion Rees.
Thank you, Bernadette, and Tracy, excellent as always. And thanks, Chair, colleagues and the public for giving time to listen to this. It's wonderful personally to be able to contribute to something like our climate change strategy. I'm not an expert, but I'm one of the many people who are concerned. And I hope we all accept now that climate change is real, and that it's inexorably tied to health. We can talk at length about what's happening, but the reality is that carbon dioxide levels are higher than they've been in the last 800,000 years. And we are all seeing things if we keep our eyes open. And responding to climate change is going to be one of the biggest challenges that we face this century. And it's becoming something which is moving far beyond individual actions. So it is wonderful that the behaviours of CCG employees have changed before and are continuing to change, but that isn't going to meet the scale of the action that's required. And as a CCG and a governing body, I'd really encourage us to take on this challenge, you know, to have ambition, to have courage, and to take decisive action. Because if we lead on this, there's a very good chance that others will follow. Now, as Bernadette has said, you know, we need to know, well, how are we doing right now? And I think we need some form of external audit to robustly provide the information that gives us a benchmark that we can progress from. Because at the moment, we tend to have poor quality, but well-meaning data, or the national data. And I think it's quite important that we move towards achieving some form of standardized award or accreditation, because I think it clearly puts a public message out there that this is something that we are committed to, and it enables us then to talk with our partners and those that we commission with, and to progress that agenda. I think the carbon literacy training is a wonderful addition, and that will help us move in the right direction. But the biggest challenge is being able to move at the pace that we need to meet that net zero challenge. That's an incredible challenge. And I've seen too many of these targets before, and there is no way we're going to meet that unless we really do provide a platform for people within the CCG to meet that challenge. I think we're capable of doing it. And I think the work that's come from when Colin Watson prompted us to act, and the incredible progress to date by Bernadette and by Tracy and by Sophie and by the activists, it shows us that we can do it, but we do need that platform now. So with that, I'll pass it over to the group, and hopefully we can progress things together.
Thank you. Can I just make one other comment to wrap around everything that we've said, and thanks to Bernadette and Gwydion for excellent work on this. This isn't about lobbying governing body for more money or resources on this. I think it's about working through, so to come back to your question, Dr. Wilson, working through the asks on 4.4 within the paper, and does the governing body have the appetite for that, and is that what we would see, I think, then fitting under our strategic objective, which lines with this. We can then work out what the capacity, what the cost of doing that may be, and what could be repurposed within the CCG to do that, not necessarily about extra resources. So I wouldn't want it to be seen as a lobbying for extra resources at this stage. It's about where are we in our hearts and minds, and how committed are we to this. We'll then work out what that means and what is needed, because I think otherwise we could lose the ask that's there. So, and I hope we can all agree that those things that Bernadette listed are the things that we want to push forward on. And then I think the job is for us as a team outside of governing body to work out how we do that and do it well. Thank you very much.
Thank you very much. And I'm glad, Tracy, that you mentioned our strategic objectives. So to my mind, this is one of our strategic objectives. We need some clarity perhaps about exactly what the level of ambition is on that strategic objective. But if we set that as a strategic objective, then that is one of our objectives, isn't it? And it sits next to the rest of our objectives, and it has a call upon the use of our resources in the same way as our other objectives have a call upon the use of our resources. And that will be under executive control, won't it? So I've got comments from Peter and then from Dan, please.
Thank you very much, Dr. Wilson. I've very much enjoyed the paper and listening to the presentation so far. Interesting to see the reduction in business travel, and I think you could add to that the reduction in unreimbursed travel between home and office, which is quite significant for some people in this day in, day out. Having said that, I think we need to offset against that the cost of heating our home office spaces, and I'm talking with a rug over my knees right now. But there's something a bit more tangible, which might, which I'm sort of suggesting we make a small change to what you've proposed. In the action plan, 3.3 and 6.4 both refer to premises, business cases, etc. And they're both marked red at the moment, implying that we can't take action there. Now, my understanding is that new buildings in the NHS are now supposed to be zero carbon. The good news is, from ones I've seen so far, it doesn't have a huge impact on costs, which is interesting. But I think in both 3.3 and 6.4, we need to be making a stipulation. If we do have an appetite for this, we need to be making a stipulation that new premises where the CCG has an influence on a business case or perhaps a primary care premise, we insist that it's zero carbon. Now, as part of that, we might have to accept that there's a small increase in costs coming from that, but that relates back to our appetite to actually do something about this. So I'd like to see that small tweak, if possible, in terms of zero carbon for new buildings. Oh, the second point, sorry, was is this reflected in our procurement policy right now? So I think we need to check that one out. Thank you.
Thank you, Peter. There may or may not be an immediate answer, but I'm sure colleagues can come back if there's not an immediate answer to your points there. Is anybody able to address them?
I'm happy to respond to Peter's questions. really good point about zero carbon neutral premises, etc. So there is work underway looking at the future of what our needs are around premises, not led by me, but that's one of the points that I raised, that we need to make sure that whatever we do is considered within that. So I'm sure we'll talk about that further in other meetings. I don't know about the procurement policy, but your help and eyes on that, Peter, would be really super. So thank you for that.
A very skillfully played forward defensive from Tracy there. Thank you very much. Dan, you have a point.
Yeah, I mean, first of all, I want to just reiterate and thank Tracy for making the point that I'm glad we deferred this so we had a proper chance to take it all in, because I think it's a really important point. I'm really pleased that we are taking such a view on what is as Dr. Rees said, it's one of the biggest challenges we've got in the next 100 years, and to take a view on something which is so long term is brilliant. I suppose I was looking in terms of the proposals and whatnot, and I understand the basis for wanting to know where we are as a starting point, but I guess I wouldn't want that to be a block to starting to make some change today and start to measure that change. So, I was thinking in terms of, we've talked a bit about propellant use for inhalers or LED lights. It'd be nice if there's some way of being able to visually see that and use some kind of dashboard where we can almost gamify it, so we know that different parts of the region are starting to make those changes or not, just so we can assume that's going to have an impact on the CO2 levels, but we don't necessarily have to have that benchmark before we start. I suppose the other point I know you've mentioned here as well, and Peter just mentioned as well about the reduction in car use. Obviously, that is in relation to COVID. It's probably not going to be sustained, assuming that things get back to a relative normal afterwards. And you've talked about having access to electric cars. I just wonder if that's something we should be thinking about accelerating or trying to promote, given that what we've seen in the press in the last few days in terms of the plans for 2030. So it's just trying to take a more holistic view about how we can start to take advantage or not take advantage of, but be cognizant of what's going on in the press at the moment as well. So just those points.
Thank you very much, Dan. Does anyone want to come back on those points? If not, I can move forward to other comments.
I'm happy to. So section 4 of the action plan talks about travel and logistics, and certainly Linda Risk is leading the new ways of working group and the staff involvement with that, and I think that it's about meshing those things together about the culture and the organisation as to how we work, how often we work in an office, but also the comment about including electric vehicles in there. I could see Dr. Rees nodding, so I'm sure we can amend the action plan to include thinking along those lines, and that comes back to the premises as well, doesn't it? In terms of the measure on the what is our current carbon footprint, I don't think we are suggesting that we spend an awful lot of time and money and energy on that, but I think that it's most places that have seen great success with this have been able to benchmark their current status and then push off from that. So that would be a key action. Otherwise, how do we know that we're making any impact? So I wouldn't want to compromise on that, Dan, but I wouldn't want it to become a massive task in itself. But I think that's something that we'd want to see as an important step forward, so that we can provide you with a nice graph to show the progress that then motivates us to do more, but not spending a lot of time and energy on it.
No, just to respond to that, Tracy, I'm not suggesting we don't do that. I think it's really important that we do, but I'm saying that there's that we can start to measure the difference we're making within our own data without having to necessarily worry about the benchmark first. We can do that alongside it.
Lovely. Thank you very much. I've got comments from Claire and then Wendy, and then I'm intending to summarise and wrap up unless there was any burning issues following that. So who was it? Oh, my memory. I know Wendy was coming in. Who was it, the person? Claire, sorry, Claire.
Do you want me to go first? Okay, so very supportive of this, and I think we do need to do as much as we can, but I know it's implicit within the paper and within the discussions that we don't do this on our own. Both Ian and I were at Cheshire, Western Chester Health and Wellbeing Board yesterday when there was an environmental management strategy paper discussed. There was something in the newspaper this week in terms of Cheshire East Council social value and the leader, Sam Cochrane's promotion of sort of the environmental issues. I was at a Council of Chester strategy event. It was seems ages ago, probably in January, where there was a really interesting discussion about all the work they're doing in terms of sustainability and the wider environmental agenda. So I think for me, absolutely as a CCG, in line with our strategic objectives and our ambition and vision to be, you know, sort of leaders in this, but we do it as part of a public sector, and we do it as part of Cheshire. We don't create our own strategy, we don't create our own targets. We have to sort of, we look at the synergies there are between the ambitions and the plans that other organisations have got. It would just seem, you know, almost counterintuitive and contradictory to be doing something on our own when this is a sort of, you know, the environment of the population of Cheshire that we are all working for. But I think really good work, and thank you very much.
Thank you, Claire. Wendy.
Thank you. Yes, I would echo what Claire has just said, because some of these issues are really out of our control. There are things within it we can actually work towards, and there's a lot of really great suggestions there. The one area I was thinking of was the single-use plastics, which we, unfortunately, via COVID, have actually generated vast mountains of, which is going to be a very tricky issue because it's so ongoing and continuously so. Our procurement and our work with others on recycling of these plastics has to be on a broad regional level, I think, and beyond. But I also think that we could be looking at our commissioning and actually inserting in part of our contracting arrangements that we will be expecting our people to in the region to be conforming to this. It happens elsewhere, so I don't see why we can't actually stipulate that our expectations to really make an impact.
Thank you very much. So thank you, colleagues, for all the comments on that. And I think we're all in agreement that it's an enormously important piece of work for us. We're asked to do a number of things on this paper. We're asked to note the action plan and progress on climate change between January 2020, from January 2020. Note the action plan for October to March 21. Note the recent publication of the Delivering the Net Zero National Health Service. And then agree a revised level of ambition and required resource allocation for delivery of a net zero Cheshire NHS by 2040. I think, and correct me if I'm wrong, colleagues, but I think what I've heard is that we do wish to be able to take that to be our ambition. I suspect that following that, we probably need some more details about what the consequences and what that would look like. So is there a proposal, Tracy? So what's the next steps proposal on this?
So I think if we gain that agreement, and I'll work on the premise that it feels like everybody's up for that, we need to then work out the resourcing, that what is required to deliver the revised ambition, and it's about how can we do that. And I think the points that Claire and Wendy made around this isn't just the CCG working in isolation, it's about locking into all our partners and doing this as a system. So it's about then how do we resource that. I would propose that we can handle that through execs, if that would be useful. But I do think it's good to have a 6-monthly update report so that governing body remains abreast of this very important strategic aim. So that's how I would propose to handle it, if you agree.
That sounds very sensible to me. I'm going to pause and go back slightly just to check that we do have that. I'm like you, Tracy, assuming from the conversation that we do have that agreement on that ambition. I'm just going to pause to check that we do. I believe that we do from all of those nodding heads. So brilliant. I think then we are agreeing with all those points and with your proposed next steps. Thank you, Tracy. And thank you to you and for the teams, and particularly for Bernadette and Gwydion, who I know are passionate supporters of this work, for their work on this. So thank you for all involved. So thank you, guys. I think that takes us forward to item 4.2, which is the NHS People's Plan, which is on page 40 of your packs. Matthew.
Thank you, Andrew. So I'll just give a brief summary. Hopefully we can spend some time on some of the asks and any other questions you might have around the CCG actions so far. So just in summary, we are the NHS People Plan, was published in July, and it built on the interim People Plan that came out the previous year, but also a number of other documents that have been produced over the recent years around improving staff wellbeing and working for the NHS. It was heavily influenced by the onset and the response to COVID, which you can probably see throughout the document. And ultimately, it sets out really what NHS staff and its people should and can expect from each other and the NHS. And this is sort of encapsulated within the people promise, the rainbow diagram that you can see. There are a number of specific commitments which I've highlighted around looking after people, belonging in the NHS, new ways of working and growing for the future. And as a CCG, we need to not only do our own thing, we also need to link into what our partners are doing, what the system is doing and region. And people are at slightly different places as to where they're implementing the requests and actions of the people plan. But just to give you some assurance, I am linked into the Cheshire HR directors, and we do talk about this, but I'm also linked into both the regional and the national sort of work streams on this. So I've given some links and details to what's out there in terms of the North West and Cheshire and Merseyside, and I continue to report back on that. Other key point to make is that some of the actions have been sort of highlighted for this financial year. But clearly some will go over into future years as well. And we're due to receive some further detail around some of the metrics as such that are aligned to the people plan that will form part of the oversight framework of the NHS. So again, it'll be really a reiteration of what we need to do as a system, as well as what we need to do as a CCG, ICP and other things going forward. What I've put within the document for you is a link really to the CCG framework of how we're addressing the myriad of actions that came against those 4 commitments or 4 areas of commitments as such, and where we're currently planning on meeting the requirements or what we need to do over the coming weeks and months to meet those requirements as well. So I'm sure you might want to pick up some points on there, so I'll move on quickly on there. There are many important points in that, but I've tried to highlight in section 4.4 some key things for you to consider as a governing body. One, the first sort of point is want to give you some assurance in terms of what we as a CCG have to do in terms of keeping our staff safe in some respects, especially around COVID-19. And as you've all had to do your risk assessments, but as a board, just wanted you to highlight where we're up to in terms of making sure all our staff have their risk assessments. We're now at 98% rather than 96%, so we're gradually getting there to 100. We've got a really robust system in place now to make sure new starters, it's part of the first thing that they do around induction, as well as maintaining even when people leave. I'm sure we'll come back to this, Andrew, but not a stated statutory requirement of organisations, but a strong emphasis and recommendation is that organisations appoint themselves what is known as a wellbeing guardian. Now, as highlighted in the paper, that doesn't take away the responsibility corporately and operationally for the chief exec, who has got that duty around the wellbeing of our staff, as well as my dual role in that sort of sense. But there is an ask that there is a board level, I'm going to say, sponsor around wellbeing. And what I've highlighted in the paper is the current draft guidance around what that role potentially would encapsulate. And again, it's one of the considerations I'm asking today as to whether as a CCG we wish to progress that, and therefore if we do, I can progress that. Really, one of the key things that came out of COVID, as well as the people plan, and also followed up by really some of the high-level actions against health inequalities, were these 2 things around recruitment and promotion practices for NHS organisations, as well as leadership diversity. And whilst you can see that some of the emphasis is on the Black, even ethnic minority, it also encapsulates all the protected characteristics. So I did want to just re-emphasise that, if not fully captured within the paper. There's a fair amount of work that has been going on and continue to do to really look at our sort of recruitment, advertising, promotion practices for people to see us as not just a employer of choice, but is our processes, not how can we mitigate against unconscious bias, which unfortunately organisations unwittingly do sometimes. A real key challenge that came out, again, not just from Action for All, but also around the sort of phase 3 letter and the actions around health inequalities, was this challenge and ask for us to come out with an action plan to see how we can make our board more diverse, but also as a whole our workforce. And I've highlighted within the paper the ask. What I've also highlighted is some benchmarking information, and I'll give some caveats on this in that, the caveats are both based on 2011 census data. There are some caveats that some organisations capture what they class as being slightly different than others, but they are a good starting point. And Table 1 highlights some that might help to influence what you might wish to set as a CCG. The last sort of things I'll just highlight to you is the bit on around accountability and what will be coming out in terms of consultation around competency frameworks for board members, for all board members in the NHS. Many of you will know about the well-led sort of framework that providers are held to, whether it's going to be an expansion on that. Once that consultation's out, I of course will inform the board around that. And last but not least, and equally important, is the ongoing work around freedom to speak up. As you're aware, Peter is our freedom to speak up guardian for the CCG. We're a lot of ongoing work to try and raise the profile around that, what's formerly known as sort of whistleblowing. And again, it's a key emphasis really within people plan around, creating that safe culture for people to speak up when needed. Andrew, I'll leave it at that because there's a lot of information in there in terms of the links, so I'm quite happy to answer any questions where I can.
Thank you very much for that, Matthew. Suzanne, you wanted to come in.
Yeah, thanks. I thought it was a really good paper. I thought it was a really good start of direction of travel and where we're going with things. I had a couple of comments specific. On one, we talked about car and travel with staff, and I thought there was a good opportunity there to link that into the climate control and electric cars and stuff like that. But the other one was on retaining staff. It's really useful to learn how to retain your staff from those that leave. So conducting exit interviews is a really good way of learning what's going well and what isn't going so well, so you can feed that back into the process. So that was something I would say perhaps wasn't as visible, but perhaps would be really beneficial as well.
So Suzanne, we do have access to that kind of data where it's not confidential. So that kind of workforce metric does come back to me as well. But and good point, really, the environment. There's a lot of work that we wish to do around alternative transport and the offers that are available to staff and members of the CCG, which we're currently working on.
Thank you very much. I've now got a number of colleagues who want to comment. Peter has raised the point. There are two specific points for us to consider, which is the appointment of a wellbeing guardian and the challenge around diversity on the governing body and more widely. So I will, Peter, come back to each of those separately. Do you want to come in and give your views on each, and then we'll summarise it when we've heard everybody's?
Thank you, Dr. Wilson. Yeah, I can probably, there's only a very quick comment about the wellbeing guardian, which is the relationship between that role and the freedom to speak up guardian, because quite clearly there's an overlap, but it does actually, thinking about it, it does actually give a referral point for the freedom to speak up guardian in certain circumstances. So I'm sort of more, I'm warming to that idea. On the leadership diversity, I've got a few problems with this really. The 5-year time frame that we're talking about there is far too long. to think about from my point of view. And I'd be wanting, if we're going to agree anything today, I'd want not only a trajectory which takes us where there's some staging points, through that time frame, but also some granularity there, because quite clearly, achieving the right ethnic mix or a target ethnic mix across the workforce as a whole is totally different to achieving it at governing body level and at senior leadership level. So I think if we were going to do anything sensible around that, we have to set targets through the years, and also segment it into if I can, for want of a better description, layers of the workforce. Because a 2025 target means nothing to me right now. Besides which, by the time we get there, the ethnic mix could have changed a little bit. So we'll be like a tortoise and a hare, and we'll never catch up.
Thank you. I think Matthew's volunteering to come back on that.
Yeah. So Peter, do not disagree. It's not a perfect world. I think one of the things I was going to reflect on is that a lot of the actions in terms of their terminology and targets are very provider language, and it's how sometimes you apply that to us as a commissioning organisation. The 5-year target is the 5-year target. Absolutely, as an organisation, we can be more ambitious and cut that period down. We will at some point data, because the next census is due next year, and then however long that takes to get that data out, that'll be we will get some more up-to-date data within the next year to 2 years. I think your point around how do we work through, I'm paraphrasing, sorry Peter, the difference maybe at a board level, senior team level and the whole CCG level is a good one. But it is a challenge in terms of organisations that are relatively still small in terms of its size, and with less than 300 full-time equivalent staff. In some respects, hitting a percentage could be easily done, but equally it could be challenging. And it's my early point before is we've been set a target around diversity, and the diversity is under the Black, Asian and ethnic minority, and that has come out nationally, but we equally do need to recognise the other protected characteristics in terms of our diversity conversation as well. So, but I'm just relaying what has been asked of us as NHS organisations, and the Black, Asian and ethnic minority ethnic target has been set to us as something we need to achieve. So hence the ask today.
Thank you, Matthew, and thank you, Peter, for your comment. Can we move on and to Suzanne? Oh no, Suzanne, you've done yours. Sorry, Fiona.
Hi, thank you very much. So again, on the 2 comments, I am also I think I would support both of these things. I think having a wellbeing guardian is a good idea. My concern about it is about all of these things is we don't just want to say, yeah, we've ticked that box. That they have to have a specific remit. And if you ask, it might be different where everybody else is working, but if you ask in general practice, one of the things that people are struggling with, and this was before COVID, but is worse since COVID, is the public getting shirty and unpleasant and making their job difficult. So it's not just about providing, here's another website you can go to improve your mental health. I think we've received those, thankfully, from people who've provided them. But actually, we need somebody who's brave enough to stand up and say to individual people, you don't treat the staff like that. Now, you wouldn't allow people to come in when we used to, down at the Barony, you wouldn't be allowing those people to come in through the door and abusing your staff face to face. We do struggle with that, and I know the hospitals struggle with that. And so we've got to be quite clear that well-being is also about feeling that you are being valued at work by the people you are doing the work for. And so that would be my plea, that whoever is going to be looking at that actually realises in my view. This is a tough ask, but I think we should do it. And the second point about the BAME, etc., is that I mean, I think I did say last time, I am in favour, because this is often the only way things get done, about positive discrimination. But I think what I was hearing is that we need to do it right from the bottom up, because you can't suddenly become a chief executive. You have to have worked, you know, you have to have the relative expertise and experience, and so what we need is homegrown, and so we need to be out there positively promoting this and thinking about some of the leadership roles that we have talked about, and I know were mentioned again today. We need to go and offer them. Now, I appreciate that there might be a bit of a governance issue about offering some people rather than others, and I don't know how you square that circle, but I would be in favour of positive discrimination, because that's the way we'll get things moving, and then hopefully it won't be needed. Finish.
Thank you. Yeah. Good points. Claire, can I bring you in, please?
Thank you. Firstly, thank you, Matthew. Really good paper, and thanks for your work on this. Appreciate your working across the HRDs in Cheshire. So very supportive of the Wellbeing Guardian. Just sort of really keen though, sort of top of page 45, it does say the sort of the primary responsibility for health and wellbeing of the staff lies with the accountable officer, and I take that really, really seriously, as do I know my exec team colleagues. So I'm not taking anything away from us, but I do think that sort of, I think it talks about a critical friend, I think is really helpful. And I guess it's that double act really in terms of governance and accountability for that. I think the other point in terms of sort of positive discrimination, succession planning, supporting development of staff, and I suppose it's not just the staff, is it? It's the roles in the governing body, it's the clinical leads, it's all of those. That's a really interesting conversation, particularly in light of people's appointments and sort of 2-3 years and how we do that, and then obviously staff with permanent contracts. So very supportive to look at that. I think it will be an interesting discussion when we get into the detail going forward, but I think it's a good piece of work, and I think it's something we need to keep coming back to, which is one of the other recommendations, that we come back on a 6 monthly or quarterly basis. Thank you. Thanks, Matthew.
Thank you. Sorry, I was muted. Thank you very much. Wendy, you wanted to come in as well.
Yes, thank you. I obviously love this approach, because 1 and 2 on the evidence thing that Matthew put is obviously good employment practice anyway. I think, given what everybody's been saying, we have an advantage and a disadvantage, because the advantage is we are relatively small as an organisation, so we can get our arms around a lot of these issues and address them. There is considerable work on looking to increase the diversity and equality and diversity issues in a predominantly white area of Cheshire. It's actually very difficult and tricky to make sure that we do represent our population appropriately. However, there are a lot of things that we can do internally, and there are lots of areas that we can go to for help to access that on our general recruitment, etc. So I'm not too despondent about that and as trying to address it. And I think the very act of addressing it is actually helping to raise awareness and that unconscious bias that Matthew mentioned. So there's a great deal that can be done in that area. I think my comment is, are we being ambitious enough and interpreting the actual requirements from NHS generally? Because for me, and I think that's what Fiona was really referring to, is that actually our GP population are the people who we need to be nurturing, building, growing, because of the expansion, hopefully in the years to come, of the types of work and the breadth of the work that they take on and the expectations of our population. So having a much broader strategic people plan that actually draws in a lot more, which links to our strategic objectives. If we want to deliver X, then we need to make sure that Y and Z can actually do that for us. So having a longer term approach for people who are actually out there on the front line and are actively helping to develop and point us in the right direction clinically. So I think that we need to have rather than just saying, yes, we are doing it, and we're looking internally at the 300 and odd people in the CCG, you know, the internal people, we need to be looking externally as well, and looking at our people that we commission with and on the people side. So I think there's a bigger piece of work there as well that we could be looking at, and linking and integrating some of this more intensely.
Thank you, Wendy. Very pertinent and good points. Tracy, you wanted to speak, and then I've got a quick comment from Andy, and then we need to wrap up.
Thank you. I've read this really thoroughly because I think it's vitally important that we get this right. I really like the action plan, so I'm very supportive. Matthew, I think it's been very well put together. I suppose I just wanted us to reiterate why it's important to do this. It's not about achieving targets, it's about the evidence that organisations that have a more diverse workforce and are able to nurture the requirements of different requirements of protected characteristics then tend to be higher performing. So I suppose it's not just doing it because we're being asked, it's doing it because this is the right thing to do. It makes us more representative of our population, and it will help us to achieve more. So I'm really pleased you've included the Equality and Diversity Steering Group. I know many of our partner organisations already have those in place, so I guess it's copying from those. Because I suppose I'd like this action plan to be owned by our staff, so that they feel that they can feel that difference and the improvements. So I guess it was just to ask, not necessarily answering now because of the time, but how can we promote this so that there are lots of staff who I think have things to offer and want to offer, can get involved, and it's, you know, modern. And then also not now, but how do we then make this available to support our primary care networks, so that they can benefit from some of the learning and grow their staff and workforce in line with the work that we're doing here. So, but endorsement from me, thank you.
Thank you very much, Tracy. And I think you're probably picking up slightly there on Wendy's points about how we take a leadership position, perhaps how we coordinate, because yes, we can do things in the CCG, but our providers are already doing some of these things, and how can we link in and connect with those things, rather than, so we can again act as a system rather than acting as individual organisations within that system. So Andy, if it's a very quick question, I will take it when we do need to move on to discussing the specific points. Peter's point is what is the target percentage. I'm going to, just a warning, Matthew, I'm going to ask you to talk us through how we reach, consider and agree a target, it says. So I'm going to ask you to talk us through that in a second. So a warning on that, that's okay. Andy, your point, please.
It expands on Wendy's, Tracy's, and your last point. Thank you, Andy. The people plan, for quite a lot of people, when they hear the people plan, it's actually a recruitment. So I'm looking at how do we recruit. The rainbow is very welcome. I love the colours, but part of that strapline could be we are few and need more colleagues. And when we talk about HR relations with secondary care within the paper, perhaps we do think about primary care and active links into primary care and what those approaches should be, because I think the way the primary care approaches HR is quite piecemeal. You can have bigger organisations doing this far better, and the CCG is more well equipped to do this. I think primary care is a weakness and is the majority provider when it comes to the number of staff within our system. So just thank you.
Thank you for that. So I'm going to just go through the recommendations that we've been asked, and then ask Matthew to talk us a little bit through more how we might at this point agree a target, and I'll make a comment on that before he does that. So we're asked to note the actions required of the NHS employers, including CCGs, and progress them against actions taken. I think we can do. Consider whether the clinical commissioning group should have a named governing body, a member for the organisation who will be our wellbeing guardian. I'm going to look now to see whether we feel that is the right thing to do, and if we do, my suggestion is that I will work with you all to identify one of us to be that person. So the question is, do we believe that will be helpful thing? I did think that Peter was volunteering or self-nominating earlier, but then he did manage to clarify that he wasn't, but I thought that he was. I'm disappointed that he wasn't. Anyway, colleagues, do we feel that's a a good thing to have. So perhaps just a indication with nodding heads. We've got mately nodding heads. Thank you very much. I'll work with you outside of this meeting then to identify somebody who's willing to, and enthused to take that on. So volunteers, please notify yourself to me, and we'll work that out outside the meeting. So Matthew, taking us forward then to this target, there is a requirement or ask that we consider a target. You rightly point out that we need to consider all protected characteristics, but this is specifically about BAME. And you and I have discussed this outside, and whilst the ask is for the organisation as a whole, perhaps for the governing body, I'm going to make it even more segmented by saying I think we should think about our GP elected members, myself and my colleagues, separately as well, because I suspect, although Matthew hasn't been able to confirm, that the diversity within our GP population is probably completely out of step with the diversity of those people sitting on the governing body in terms of GPs. So whilst the BAME population for Cheshire is lower than many parts of the country, I don't know whether it is amongst our GP colleagues who make up the electorate for the selection of our governing body members, and there are no BAME colleagues, to my knowledge, represented on the governing body. So Matthew, do you want to talk us through how we might come to a solution about a percentage and what your recommendations are on that?
Okay, thank you for that, Andrew. Dave Hartley, thank you. It's surprisingly hard to get a really accurate figure, and it was really hard to get one for Cheshire, because that's the ask in some respects. You know, if your current workforce was higher than what your local rates are, then you can choose to keep to that one, or as others have said, we could be even more ambitious. So hence why you've got a variety of percentages on table one. I looked at our close colleagues in terms of, you know, what their percentages are as they've reported, recognising that they do have a different workforce mix and therefore potentially attract, you know, colleagues that we might not in some respects, and then looked at our local authority areas. So the other element was, you know, do you split it? Do you keep the same target for a board as you do for your senior leadership team or as a CCG, or are you saying out of your 300 staff, we're looking at a 5% target? So that's part of the ask today, really, whether you think it's a global figure for the CCG, or whether you wish to be more specific and say, if you agreed 5%, it's 5% at board, it's 5% at senior leadership team, and it's 5% for the organisation. That really is the ask, and you know, if you look at the figures in really table one, then you are probably looking at, in terms of the geography, you are looking probably closer to the 4 to 5%, which is an increase on what we are currently as a CCG. If you wanted to be really ambitious, and someone like NHS England has been really ambitious in terms of they are, you know, saying 19.7%, then I would want you to just reflect on what Wendy was saying earlier in terms of the challenges that does bring. So I equally understand where Tracy, you know, it's not about the target, you know, there's far more to it than a target. So in setting a target, it does allow us to reflect how ambitious and how maybe affirmative action, I think, is what Gwydion has put in the box around recruitment to the C. So I'm not going to recommend it's 4 or 5 or 6%, because that's part of the debate I need you to consider. But just please take on board the earlier comments that people have made around the challenge that we'll face. And if there was another recommendation, I think what Peter talked about is, do you want to keep to 5 years, or do we want to be a little bit more ambitious in terms of timelines?
Thank you. It feels like there's quite a bit to debate in there. We are relatively short of time. Matthew, is this a decision that we need to make on this occasion, or can we come back and give it?
Not today. Again, I've deliberately not gone into the house and, you know, how we could do it, because that will be influenced. So if people need to think on it and then come back, then there is no challenge on that. If it's useful to come back in December, then we can, or in between now and December, that's fine.
Okay. So I think I'll take comments from colleagues then, with the possible going to a position that we give this more consideration at a future meeting, because I think it does take some useful debate on this. So are there any comments, but being mindful that the intention is to come back on this? No. Okay, thank you. So I think we can agree with all those positions. I think we can agree that we do wish to set a percentage and an ambition, but that we need a bit more time to have that debate and discussion to come to that conclusion. So are we in agreement with that? Yeah, thank you. So we'll bring that back. Thank you very much. The next item on our agenda is 4.3, which is designated places, which is deferred or cancelled. So that takes us forward to 5.1, which is the finance report. And we haven't had a finance report for some time, so we have got a brief finance report. Important that we keep abreast of where we are with this, in addition to hearing the finance committee report. So Linda.
Thank you, Andy. I hope everyone can hear me. So I have no intention of going through the report in detail, because obviously we do that at the Finance Committee, but I'd just like to draw out a few issues that I think are definitely worth noting. So the deficit we currently have to the end of September is 2.147 million. Usually we receive that money, an additional allocation in the following month. We haven't received the allocation to cover that in October, but we anticipate doing so in November. Overall, we've received this year an additional allocation of about 22 million, which is covering additional spend on COVID of about 18 million. We are clearly still operating under a COVID financial framework. As yet, we have not had the budget agreed for month 7 to month 12 for the CCGs, but we have submitted plans. The plan that we submitted at time of writing of this paper and for the Finance Committee showed that we would anticipate a deficit to the year end of 11.5 million. Further information on this in detail is actually shown in Appendix A of the agenda item 6.1 under the report of the committee chairs. This has again been discussed in detail by the Finance Committee, but there's more detail there if you wish to review it. As I said, this was the plan as at the time of the Finance Committee. Since then, we have been asked to do a further return by NHS EI, and we have now put in a new plan which has a reported deficit of £10 million, so an improvement of 1.5 million. The improvement is based on a further review of the financial position of the CCG as at the end of October 2020. There will be another submission on the 4th of December. So we are constantly doing this iteration after iteration as things change. So just to be aware of that. In terms of looking forward for next year, we have not had any guidance yet on 21-22, but we anticipate that we will get some more information towards the end of the year or early in January, which will enable us to start doing some proper plans going forward. But we are, I assure you, thinking about it now and are planning to take something to the Finance Committee in December. Just to draw out the key risks, the key financial risk for the CCG is that the position in terms of the recurrent impact of COVID is unknown. And this will have a major impact on the sustainability of the CCG going forward. So that's something that we really need to consider, and will be doing so as we move into our planning for 21-22 and into the future. Thank you, Chair.
Thank you very much. Are there any comments or questions for Linda on that finance report, please? No, I believe colleagues are content. Oh, that must have been you were clear on that. Thank you, Linda. That moves us forward. I'm just pausing slightly because in case there are a comment. No, that will move us forward in the agenda. But I've just got a quick comment, please, Linda, because though the presentation is largely about how our position is, I'm particularly concerned about us understanding and knowing what our position will be going forward. It's an extraordinarily odd year that we're working in, isn't it? And where we are is not a reflection of where we will be next year. And so I suppose it's an ask to that clarification and I suppose a reassurance from the Finance Committee that we are on with that and understanding what our underlying position is and the plans and mitigations that we need to be taking forward to address them.
Yeah, so at the moment we are definitely waiting for more information about the financial framework going forward. Also how this will work in terms of ICS, in terms of system by default, obviously as part of the Cheshire and Mersey system. And until we get that, we can't sort of do anything with any great certainty, but we do need to start looking to see what this would look like based on a set of assumptions. And that is what we are planning to do for the Finance Committee in December. And then again, if we could discuss it probably informally with the governing body initially until we get some certainty. That's what I would think.
Thank you. That sounds encouraging. Yeah, we can make a certain number of reasonable assumptions, can't we, about where we're likely to be, or even if it's only sort of a worst case scenario, a middle case scenario, and a best case scenario, depending on what happens with decisions about finances. And we can probably assume that our worst case scenario is nothing changes from where we were pre-COVID, and all those assumptions are taken forward, and a plan to address that position would be reassuring.
Yeah.
Thank you very much, colleagues. Nobody else has. Oh, Claire, you want to come in?
Thank you, Andrew. A similar query to yours actually. I mean, I appreciate the Finance Committee go through this with a fine-tooth comb, but I think it's just, I guess, how much the conversations we have at governing body and in terms of that future strategic financial plan. You know, we have presentations around commissioning contracting intentions. Also, for me, we need sort of financial strategy to run alongside that, recognising all the uncertainties. But I think, as Andrew has said, we can't just say we don't know. We have to anticipate. We can in terms of our expertise look at, you know, activity and spend and overspend in previous years and do some forecasting. And I think that's what I would like to see going forward. So I welcome the opportunity to have this as probably a deep dive in one of the informal sessions, or whether we need a extraordinary Finance Committee where more members of the governing body attend that or something, so that I think as a governing body we have greater scrutiny and influence over the financial strategy. And I think we need to bring that back early in the new year for April 2021.
Yes, I think that's a very reasonable ask, and I think we need to do that. But we do have to be cognizant of the fact that there will be more guidance coming out from the centre, which may have a significant impact on that. The other thing we are doing is I'm discussing this with the directors of finance in Cheshire, the chief finance officers across the CCGs in Cheshire and Mersey as well. So it's not that it's not being discussed, it is being discussed, and we are considering what we need to do next.
No, I appreciate that, Linda. I think it's just bringing that assurance to the governing body.
Yes.
We are part of many different systems and geographies. I think it's the accountability and the assurance that the governing body need that those discussions and those plans are being considered. Thank you.
Lovely. Thank you very much. I think that was helpful. So I think we can take that, if you would, Linda, as an action, understanding the complexities, the difficulties, the uncertainties, but that I think we do need that, whether it is an extraordinary governing body, whether it's an informal, but if you could take that as an action, that there does need to be something from the governing body point of view in terms of taking that forward, accepting that there might need to be a number of scenarios based on the possibilities, but I think we need to know that we've got it covered, whatever those are, or at least know where we are, whatever those may be.
Yeah.
So thank you.
Okay.
Lovely, thank you. That takes us on to section 6.1, which is the report from our committees. It's on page 67 of your pack, and we have reports from the PCCC, Q&S, REMCOM and SCMP. Each has a degree of recommendations, but the REMCOM and SCMP have some reasonably meaty recommendations, so considerations for us. So my intention is to go to each of the chairs of the committees just to say a few words and pick up the section from your committee, if that's acceptable to you. In which case, finance is actually at the top of my list. So Suzanne, are you ready to do that?
Yeah, thanks, Chair. I wasn't sure what was happening with the format, but I'm happy to just speak. I think obviously Linda's already spoken about the finances. There has been a big emphasis, and Linda and I have had a recent conversation this week about looking forward to just get the governing body assurance and making sure we're ready for next year, and recognising there are restrictions from NHS England and I at the moment in terms of dictating finances a little bit more than we are used to. That doesn't mean we want to be caught on the back foot, so there are plans to do that going forward. I don't think there was anything else specifically to bring to your attention at this time, other than because Linda's pretty much covered what's been discussed. So.
That's fine, thank you, Susan. I wasn't looking for you to reiterate everything. It's just picking up if there are specific recommendations. I believe it's really only REMCOM and SCMP that do have.
Yeah.
So thank you. That's really helpful. So if we go to Peter, just to check in with that.
I can be very quick on this, Dr. Wilson. This was covered in the Accountable Officers report. It regards the EPRR assurance.
Lovely, thank you. And takes us then to Pam with PCCC.
We haven't actually got a report this time for Primary Care Commissioning Committee. Our last meeting was just a single item agenda, which was about the closure of the Sandway branch surgery, but I'm going to bring something back to a governing body next time in that regard.
Lovely, thank you very much. Chris, quality and safeguarding.
Thank you. So taking over the chair from Pam, and just to update the board that really following our recent governing body discussions about commissioning and recommissioning of care home beds, the committee have asked for some further assurances around two processes at its next meeting. So looking at that process for the repurposing of care home beds that looks across quality, contracting, commissioning, finance, and secondly to look at the process in place for the onboarding of new providers for care homes and dom care, so that if as a governing body in the future we're called upon to recommission or make commissioning decisions at pace, we will have a greater understanding of the processes that are in place across all of those teams for assurance purposes. So we've asked for that information to come back next time.
Thank you very much, it's very helpful. That takes us then to the REMCOM, which once again is Pam, and we did say at the start in terms of conflicts of interest, there is a potential conflict of interest for GP colleagues on this because there is a consideration of terms and conditions for a GP post, none of which is a post that any of us hold, but we could theoretically do so should we wish to in the future. I don't consider that sufficient conflict of interest that we need to be excluded from the discussion or decision, but to note it up front I think will probably be adequate. Pam, REMCOM please.
Yeah, just to draw people's attention to page 73 of the papers, because that's the area that I'm going to talk about. We had a paper at REMCOM about named safeguarding GP roles, and the committee wanted to ensure consistency in the remuneration of GPs in the clinical commissioning group. So Appendix D outlines the proposed terms and conditions which were debated at the committee. And basically what we're asking as a committee is that you agree the 4 bullet points in terms, the blue ones on your papers, in terms of the time commitment, the type and term of contract and the sessional rate for the named safeguarding GP roles. And if you will agree those, then we'll arrange for that to be put into the clinical commissioning group remuneration framework. That's it.
Is our colleague in a position to agree on that point? Is anybody in a disagreement on that point? Oh, Claire, sorry.
Not in disagreement per se, it's just understanding, I suppose, the risk and consequences of putting this post on a permanent contract as opposed to a fixed term. Is it the post? It'll be the post, not the individual, but just in terms of understanding potential risks.
Matthew, can you help me on this?
Equally, I might bring in Paula into this one as well. So I suppose the risk is like any other staff member that we substantially employ. It was part of the discussion and part of the evidence within the remuneration paper that you've got access to around. It's not so much the individuals that are currently in post, because they are currently in post. It was about the pool of potential individuals who would consider and apply for a role as well as being equally qualified. And again, a lot of the evidence from across both region and nationally around these posts being usually substantially employed, equally recognising there are some that are not as well. So the risk would be with anything in terms of taking on a substantive post and all the things that come with that in terms of redundancy and our earlier conversation today around things like pay protection as well.
Okay, thank you.
So,
thank you. So sorry, I just wanted more just for clarification. So I am supportive.
Okay, so Paula, since I asked the question whether we're in support, you've said, could you comment? Is it on that point or is it on a different point?
I wanted to make a comment on something that Christina said, and I'll come back to that after. But in terms of just answering Claire's question, I think Matthew's answered the question fully, really, and I think it's about new post holders, and I think the risks around not recruiting is greater than the risk of any potential disruption to that post. And I think that was the weighing of the balance, really, in terms of the detail that went. But it is not without its risk, but I think the risks on the other flip side of the coin were far greater. Thank you.
No, that's what I thought, Paula. I just wanted to hear it, so thank you. Thanks for the clarification.
Thank you very much. So Anne has pointed out the 4 points in blue, and colleagues in agreement with accepting those, and as a consequence agreeing to update the framework. Yeah, I believe we are. Thank you very much. Is that the end for the REMCOM? Is that your only point?
Yes, that's the end from the REMCOM. Thank you.
Lovely, thank you very much. That takes us then to Strategic Commission and Performance. A number of points for you, Wendy.
Yes, to reassure governing body that these are not long points in particular. Obviously, strategic commissioning does not have authority to make certain decisions, and that's why these are actually being referred back to governing body. The first one is actually the Cheshire-wide optimisation policy. This was actually, just as you've read in the information, to achieve consistency across Cheshire. So that is actually now in place, so doesn't really need any in-depth discussion. I can assure you that obviously strategic commissioning has dealt with these in depth during our debates. So we're asking you to ratify that particular policy. And the second one, obviously you can come back on these later. The second one is actually again another policy, and it's we wish you to endorse. And this is to delegate the responsibility to the associate clinical directors for certain decisions and undertaking this policy, neither of which is highly controversial. So I'll stop at that point before I go into the third, which actually does. Is there anything at all on those that you wish to challenge or talk about?
Wendy, could I ask, did you have a debate? I'm fully in agreement with the idea that we delegate to the associate clinical directors. Fine folk. But did you have a discussion about what the level of that is? I can see that could be problematic if we're not clear on what is a minor change and what is not a minor change. Is there any discussion around that?
We did have that. I'm going to have to ask somebody to give me a clue on anything that came out of that was controversial. Tracy, can you remember?
Unfortunately, I was on leave for that strategic.
I beg your pardon.
I don't have the detail to hand, so apologies.
Nothing comes to mind, Andrew, so I would probably suggest that nothing did.
Well, Wendy, I think if I recall, sorry, Neil here, the discussion was there was a subgroup which included public health consultants from the Christian Support Unit, clinical leads and our managerial leads for this, and they would use the view that was public consultation required, so it was how many people will be affected, you know, level of variance from any national policies, so that they would use their, I guess, educated assessment in the way we would with many commissioning decisions to determine whether it was going to impact significantly on a member of the public or large numbers of the public to determine that materiality.
Yeah, thanks, Neil, that was right. I'd completely forgotten. Okay.
Lovely. Thank you very much. I can see that Pam has made the comment that committees can write their own policies, and if it's in relation to this, I would guess, Pam, and I am only guessing, I'll open to others. This would be a question of double delegation, wouldn't it? Governing body has delegated responsibility to SC&P for them to delegate it on. They probably do need to come back to the governing body. That, I suppose, that would be a potential view on that. Are there any other comments for those two items for Wendy? No? Okay, can I take it that we are in support of those two suggestions? Thank you. I believe we are. Thank you. Wendy, okay. Please carry on.
Right, the third one took a lot more discussion and I again assure you that there was a great deal of discussion on this. It's on the contracting intentions. We had asked to have a look at these the previous month and they had been put into a format, and we noted that the format did include some longer term strategic commissioning intentions and that some were legacy in contracting activities, which needed some sort of distinction between them. And we didn't feel, the committee after long discussion didn't really feel that these reflected or were linked in to our strategic objectives sufficiently well, and that we would like to see that piece of work having a little bit more granularity in that respect. So extracting the legacy commissioning intentions, well, they weren't intentions, they were activities, extracting those from it and actually citing those at an appropriate place within the CCG, rather than just listing all these various activities which are very difficult to disentangle in terms of priorities, etc. So the discussion was quite far-reaching, and I think that we came to the conclusion at the end of it that the piece of work that is now ongoing to try to do that will be brought at a later stage back to SCAP for us to debate again and actually analyse a little bit more in detail. So that was the reason that it was actually then brought back to you to say, do you approve, governing body, for us to do those three things, which is remove the projects no longer relevant, to align relevant intentions projects to a high level strategic objectives, and identify any operational projects that could delegation down to the ICPs, which is going to become a major feature of strategic commissioning agendas in the future. So that we need to disentangle and disaggregate a lot of the stuff that the CCG is actually working on.
Tracy, do you have a comment before we make a final decision on that?
Yeah, thank you. I think just to be clear, and I think there's something that sometimes we need to all consider, myself included, about being clear on the purpose that things were being brought for. So that was actually a backward look, which was Peter Monday's suggestion that when we brought the commissioning intentions back at the beginning of the year, that we have a 6-month review to talk about progress. So that's where it came from, and it was cited as an action within the GBAF. So the ask was to review how are we doing against the existing commissioning and contracting intentions. So that was the purpose of the report that came to SC&P. So I think there is then a future report coming on. How do we construct commissioning and contracting intentions linking with the future, the existing strategic objectives? So I suppose we just need to disentangle backward look and forward look. So I think that the point I, to remove the projects that are no longer intended, is absolutely right. If they're no longer relevant and the world has moved on, that should be an iterative process anyway. To align the relevant projects to the high-level strategic objectives, that will happen as part of the next year's setting of the commissioning intentions, and to identify any operational projects within the LTPs that could be for consideration of delegation to the ICP. That will happen as part of the roadmap for the ICP development. So I guess I'm supportive of that, but I just want us to remember the purpose of that report, and I will encourage my teams to be really clear on the purpose and the ask of committees when they're bringing it. Otherwise we sometimes get a bit lost, don't we?
Thank you very much for that, Tracy. If there are no further comments, we just need to move to check our agreement with that last suggestion from SCMP. I don't see that anybody is disagreeing with those points, so we'll take it that we accept those. Thank you very much. Thank you. So thank you very much for the work of all the committees, and I know that this section now is more compact, but it's not to downplay the tremendous work that goes on in the committees and the great deal of work and scrutiny that occurs. So thank you to all those involved in the committees for doing that and for making the summaries for us. I have to say I found on this occasion that summary of what's gone on in the committee is extraordinarily helpful to know what's going on, but also to focus us on the important points. So thank you very much for everybody's work concerned in doing that. So with your permission, we move on to section 7.1, which is the forward planner, which is on page 88 of your pack, and that is to note. Are there any comments on the forward planner? It appears not, and that takes us forward then to the close of the meeting. So thank you very much for your contributions and focus throughout the meeting, which has been, as always, a long meeting. So thank you very much, and we will see you at the next meeting in December.